So just to kind of summarize quickly, when we can rely on coronary artery calcium measurement, what I'm going to spend most of my time talking about is this first segment, which is it's clearly very well suited for primary prevention decision making. We can identify much better those who have sufficient net benefit for primary prevention medications like statins, especially among younger people, not exclusively, but especially among younger people, as I'll show you. But we can also de-risk people, meaning if there's a 0 coronary calcium score, it indicates a very low burden of atherosclerosis, if any, and therefore we can identify individuals who have very low short-term risk in whom statins may be avoided very comfortably, or at least you can be more confident that withholding a statin in those types of individuals will not result in untoward events, especially, but not exclusively, in older individuals. So what we're talking about in primary prevention decision-making with CAC is really using CAC as a decision aid or a decision tool, not as a universal screening tool. And I think that really is its best use. There's also a very nice literature, and I'm sure many of you are familiar with it, that we can use CAC for risk stratification in patients who have chest pain in the emergency department, but I'm not going to focus on that here today. Okay, so if you want to read a little bit more about how CAC can be used in risk stratification and decision-making for primary prevention, I'll refer you to this report that we did for the AHA and the ACC back in 2019. And it outlines the approach to risk assessment in the US guidelines for both cholesterol and for primary prevention. And I'll summarize it as you're quite familiar with it. We first do a quantitative risk estimation with the pooled cohort equations. We put the patient in one of these boxes to classify their risk. Then we consider in a clinician-patient discussion whether there are personal or individual indicators, so-called risk-enhancing factors, that should make us think differently about that quantitative risk assessment. And then finally, if clinical uncertainty persists, this patient has something unusual, or if the patient is uncertain about whether they want to take a statin, and that's maybe the more common scenario, then a CAC score can be quite effective at reclassifying the patient's status. And then finally, of course, we make the decision of lifestyle modification or initial use of drug therapy as well. Okay, so we call this the CPR approach, where we calculate, personalize, and reclassify. I prefer this type of CPR to the other type of CPR, and in fact, this can be much more effective. So hopefully we can all follow it. So to calculate, as I mentioned in the American guidelines, we use the pooled cohort equations, which are broadly well calibrated for white and Black Americans, the intended population for the most part, and can actually also be wrong. In certain situations, as we saw earlier this morning, they can under or overestimate the risk depending on the segment of the population that the patient is coming from. So in order to kind of counteract some of these misclassifications, we now deploy the pooled cohort equations with that expanded clinician-patient discussion where we personalize the risk based on risk-enhancing factors that individual patient has. And then again, we can reclassify patients with CAC measurement judiciously used in intermediate or borderline risk patients. Okay, so we've done our calculation with the pooled cohort equation. We know which bin the patient is in. And now we do the clinician-patient discussion to really bring that more to the personal level of this individual patient. And the factors that we identified in the 2019 guidelines included the things you see here. So because these things are not in the risk equations, we can consider all of these things, if present, to be up-risking. That is, to identify a patient who's actually at higher risk than we thought they were, and therefore may be more likely to benefit from statin therapy. So family history, borderline high LDL cholesterol, things like metabolic syndrome, chronic kidney disease. Interestingly, chronic inflammatory conditions like rheumatoid arthritis or lupus also enhance the risk above what's predicted. A number of reproductive related factors in women should be considered, and then high-risk race ethnic groups, and we particularly called out South Asians because in the context of the pooled cohort equations in America, they actually tend to underestimate risk for South Asian populations. And then if measured, some of these other markers may be useful in kind of up-risking an individual as well, although we didn't primarily recommend the use of those markers. Okay, so if we've gotten to that point and we still haven't made a decision, then again, we move ahead to reclassifying the patients using the coronary artery calcium measurements. And if the CAC is 0, you can consider avoiding drug therapy and just going with lifestyle medication and, lifestyle modification. And if the CAC score is over 100, or if the patient is above the 75th percentile for their age, sex, race group, then you should consider them at much higher risk than you thought and go ahead and initiate drug therapy as well. Okay, so we just kind of reviewed this. Over 100 or 75th percentile, we're going to move ahead because they're above the statin benefit threshold. If the CAC is 0, we do recommend that you can consider avoiding statin therapy, even though you've got an intermediate risk patient above the 7.5% 10-year risk threshold. But do not avoid statin therapy in certain situations, which is patient has diabetes, patient has heavy current cigarette smoking, or a strong family history of premature coronary disease. In those settings, we know that a CAC of 0 is not as protective as in sort of the general population. Okay, so here's some data from the multi-ethnic study of atherosclerosis that really helps, I think, demonstrate why coronary calcium can really reclassify individuals. Along the x-axis, you see their predicted risk using the Poole-Court equation. The y-axis is actually the observed event rate. And so once we've done the initial risk stratification, then we add the CAC score, and you can see it pulls people apart within these groups. And specifically, you can see if the coronary calcium score is 0, then for anything from 7.5 to 20%, people with a 0 calcium score are below the statin net benefit threshold in terms of the event rate they will actually have over time. But above the 20% rate, and we're going to see this again in the future, the 0 does not de-risk them enough to get them below the statin benefit threshold. So that's why a CAC score of 0 and somebody above 20 wouldn't change your decision making. They're still at reasonably high risk where they're likely to get net benefit from taking a statin. If the CAC score is over 100, though, you can see basically everybody kind of moves to or above that statin net benefit threshold, and that's why we chose that as the cutoff point to say, you know, at this level, you would go ahead and give a statin to pretty much everybody who's intermediate risk plus a CAC score greater than 100. Now, in between, you can see mileage kind of varies, right? So if they have a CAC score of 1 to 99, they definitely have atherosclerosis. And I would say that indicates that they are on the faster track for having an event. But it's sort of a patient decision thing. You haven't really reclassified them. They're still intermediate risk. It's a higher number needed to treat than somebody who has a high CAC. So I think it's a patient decision that requires some guidance in the patient clinician discussion. Okay, so again, CPR. And that's how we use CAC in the American guidelines to really maximize identifying those patients who will have the highest net benefit and not treating those patients with medication who have less net benefit. Okay, so the topic I was assigned is this one. When should I not rely on coronary calcium measurement for risk assessment or atherosclerosis imaging? So I have 6 different scenarios where I would not use a coronary CAC measurement, and I'll go through each of these one by one. Patient 1. Any patient who has clinical manifest atherosclerotic cardiovascular disease does not need a coronary calcium score. They need a statin. CAC measurement is a statin decision aid. And so if they already have clinical ASCVD, you know the decision you need to make. The patient needs to be on their maximally tolerated statin dose. So coronary calcium is not necessary here to help you make that decision. And as we'll talk about in a moment, measuring it now will not help you monitor their disease activity going forward. CAC is not a disease monitoring tool. It is a decision aid on the front end of whether a patient in primary prevention needs a statin. Okay, so in secondary prevention, no coronary calcium measurement. What about this patient? A patient who has documented significant subclinical ASCVD from some other imaging modality. And this is what in my clinic I call primary and a half prevention. It's an asymptomatic patient, but they've got significant evidence of subclinical atherosclerosis. Now, this might have come from evidence of carotid plaque from some other type of imaging. Incidental coronary calcium seen on chest imaging, a lot of patients get a chest CT and the radiologists will say, by the way, we see incidental coronary calcification. If you get that report from your radiologist, please ask them to go back and read it, and they can actually quantify. They can just run a different protocol and quantify the coronary calcium done on a standard chest CT, usually for lung imaging or something like that. So you don't have to repeat the test to get a new coronary calcium score. You can either look at it yourself and say, wow, that's a lot of calcium, or you can actually ask them to quantify it. And then you'll have the data, sort of a two for one on the chest CT that the patient got for other reasons. If they have a low ABI, indicating that they have significant peripheral vascular disease, that would be another indication. But this is a patient who's very likely to benefit from statin. Think about them more as a secondary prevention individual than as a primary prevention individual, and you're likely to do them some good. And once again, same statement, a CAC score in this setting is really not necessary. You know the patient has upper body coronary artery calcification and needs to be treated as if they're on the faster track to an event. Okay, scenario 3, patients at high risk for ASCVD in primary prevention settings with a predicted risk greater than 20%. Well, as I showed you, and this should look familiar, if your predicted risk is over 20% and your coronary calcium score is 0, you're still at high risk. So you can't just say, okay, I'm going to get this CAC score. If it's 0, I won't treat you. I would still treat that patient because they're in a benefit group if their predicted risk is over 20%. Okay, scenario 4, a patient at low risk for ASCVD, meaning primary prevention again, with a predicted risk less than 5%. Now, the reason why we wouldn't really often use a coronary calcium for this patient is that, as I've shown you, even if you found a coronary calcium over 100, it's not likely to up-risk that patient substantially. And the yield of finding that is actually quite low. So except for certain situations where, again, if the patient has diabetes, they should be treated anyway. If they're a heavy smoker or have a strong positive family history, you might consider doing this in a young patient who has one of these findings where you're thinking about starting a statin earlier. That would make sense. But in an older patient with a lower 10-year risk, the yield's going to be low and it's not going to likely change your decision. So I would not do a CAC in that setting. Okay, scenario 5, patients who need primary prevention who are younger than 35 years, the yield here is very low. The likelihood that any patient under 35 has had enough plaque and enough time to develop calcification is actually quite low. So I would use some other tests. If you've got a very high suspicion, do a coronary CT angiogram. If you really have that high of a suspicion, don't do a coronary calcium test because it's not likely to yield anything, even if there is some plaque present. And then last scenario, and this patient gets referred to my clinic all the time. Patient got started on a statin 7 years ago. Somebody thought it would be a good idea to remeasure their coronary calcification. That is a terrible idea. And the reason is because CAC is a marker of atherosclerosis. It is not atherosclerosis. It's the body's response to maturing plaque. It's the attempt by the body to actually kind of stabilize that plaque. And so once the calcium is there, you can't make it go away. The calcium score will never go down, but it will go up in the setting of statin therapy because statins tend to passivate the plaque. They tend to make it more fibrotic and they help it calcify. So repeating a coronary calcium test on a patient who's been on a statin for more than 6 to 12 months will likely show you an increase in the coronary calcium score. I get referred these patients all the time because they're freaking out. They think that things are getting worse. In fact, it's probably an indicator that things are getting better. But remember, the coronary calcium is not the plaque. It's a response to the plaque. It will help you on the front end with your decision about starting a statin. It will not help you monitor the disease progression once you have started the statin. So do not measure it again. And that's it. Perfect timing. Thank you very much for your attention.